I have with Dr. Maria Kuptia. She is a consultant oncologist and head of the department in oncology at Shaukat Khanum, Peshawar. And we have Mr. Atif Munawar, who is a consultant clinical oncologist at Northwest General Hospital in Peshawar. We are happy to tell you that he is one of our trainees and trained in clinical oncology from Shaukat Khanum, Lahore. He did his MBBS from Qaid-e-Azam Medical College in Bahawalpur. We are happy that he's here with us. We are going to start our session with a virtual talk. This is from consultant interventional pulmonologist, Dr. Muhammad Tufail. He's been a very good friend and a mentor to me. We have worked together at Glenfield Hospital in Leicester, UK. He did his MBBS from King Edward Medical College in 2002 and CCT in pulmonology from London. He also did his interventional pulmonology fellowship from Glenfield Hospital. He's a very humble and a very good guy. So I would be happy if we could start with his presentation first. Thank you.
Hello, good morning. And I am very grateful to the organizers of this symposium, and especially Dr. Fatullah and Dr. Kausha for inviting me to talk on this important topic. So in next 20 minutes or so, I will talk about the role of pulmonologist in diagnosis, management, and especially prevention of lung cancer, and what are the new advances going on in the world, and how we can benefit our patients. So the role of lung cancer MDT or tumor board is paramount, and it has been shown that the introduction of MDT with decision making by a group of different members of different specialties has even increased the survival rate for our cancer patients. So I'm very thankful to all my colleagues who equally contribute to the care of the patients, and it is usually the pulmonology consultant in the UK setting who chairs the lung cancer MDT. So I will start with this TNM8 lung cancer staging, and if you look at it carefully, that stage 1A has been divided further into 1A1, 1A2, 1A3. And if you look at it, that if the tumor size is less than 1 centimeter versus if tumor size is between 2 to 3 centimeter, the 5-year survival rate really goes down from 92% to 77%. So millimeters matter, and it is important that whenever we encounter any patient with lung cancer, that we adopt some fast lung cancer pathways so that there are no delays in providing the treatment to our patients. So one of this example is for small cell lung cancer in our unit. So we implemented a very simple system of early warning alert system for small cell lung cancer. As you know, small cell lung cancer carries a high mortality if not treated in time. So whenever a pathologist makes a diagnosis of small cell lung cancer, they alert the chair of the lung cancer MDT, and we immediately contact the patient with the help of our lung cancer specialist nurses to come to the clinic on the same day or next day, so that we can inform them about the diagnosis, and we make an appointment with an oncologist within 24 to 48 hours so that these patients can be started on treatment as soon as possible. So this is our work from 2017 to 2018 before implementation of this early warning alert system, and then later on for 1 year. And when we compared these two groups, you can see that median diagnosis to treatment time reduced from 10 days to 6 days. And this is without any extra resources. And the same group, then when we further studied, we found that there was a reduction in 30-day mortality by implementing this simple system. So the 30-day mortality for our patients in 2017 to 2018 was 18.1%, and next year, after the implementation of this system, it reduced to 10.7%, which is very, very important for us. So in our center, whenever a patient is referred to us, so before our lung cancer clinic, the pulmonologists meet with the radiologist to go through the images and to decide what is the best modality of investigation, so that we don't have to do investigations again and again. So we studied 128 such patients with suspected lung cancer, whom we mainly performed EBUS after MDT discussion between pulmonologist and radiologist only, just before the clinic. And our data shows that non-diagnostic rate for first requested investigation for histological diagnosis of lung cancer was only 2.4% in our unit in Leicester, because we went through the MDT. We had a rigorous process of deciding what is the best investigation for this patient. If I compare it to my previous center where I had worked, where there was no such concept, where it is left to the pulmonologist only, then the non-diagnostic rate for the first investigation was up to 27%, which means that 27% of the patients have to undergo more than one investigation for diagnosis. And this is not good for our patients. We want to get the first right and appropriate investigation for our patients. So such MDTs do have their role, as we proved in our work. So the role of a pulmonologist in 21st century has changed significantly, and I will say this introduction of endobronchial ultrasound in the beginning of this century was a game changer. That with EBUS and with minimal invasive procedure, we can perform diagnosis and staging of the lung cancer and mediastinum. And we rarely perform mediastinoscopies nowadays. So it is important that we choose EBUS as a first modality of investigation where appropriate. And those who are not aware of that, that is the video showing the needle going through the lymph node and do several passes. And it carries about 90% sensitivity in the case of cancers. So this is a work from Neil Nawani in 2015 from UCL London in the lung boost trial, which has shown the efficacy of EBUS. In this trial involving six centers in UK, so they randomized 67 patients to the conventional diagnostic and staging, and 66 to EBUS TBNA as initial investigation. And this is for patients who have got stage 1 to 3A disease, basically patients who are going to have a curative intent treatment. And the primary outcome was diagnosis to treatment decision time. So it was a positive trial. You can see that when you are performing EBUS as the first line of investigation for these patients, the median time to treatment decision was shorter, which was only 14 days as compared to other modalities like bronchoscopy, CT biopsy, it was 29 days. And then when they sub-analyzed their data, they found that it is even related with increased survival. So if you are choosing EBUS TBNA as an initial investigation, you are improving the survival rate for these patients. And there are some other work going on, for example, to improve the utility and diagnostic rate of EBUS. Some people are using transbronchial needle forceps. You can see to get bigger sample. Here they are using cautery to make a hole into the bronchial wall, and through that they are putting a bigger forceps so that they are getting samples. And there are some case series, especially from India, where people are even using cryobiopsies to get bigger samples through EBUS. So there is this thing is being revolutionized further, but minimum sensitivity in our hands is at least 90%. And then we comes to transesophageal endoscopic ultrasound and guided needle aspiration, EUSB. This procedure, I mean, EUS has been performed by gastroenterologists for a long time, but there is a trend that the pulmonologist can put the same scope, EBUS scope, into the esophagus and sample the lymph nodes which are not accessible through EBUS, which are not in proximity of the main trachobronchial tree. It allows to sample paraesophageal lymph nodes which are below the diaphragm or even left adrenal gland. So the utility of EUSB has been documented very well, and if you know to do both EBUS and EUSB in the same setting, so you are using the same instrument, you are using the same session and same operator, so it will lead to cost savings. And there has been further reviews and meta-analysis by Dr. Silvestri in 2013. They say that the EBUS have got sensitivity around 90%, and it does slightly improve. But in another meta-analysis by Dr. Dhuria, the EBUS TBNA alone had sensitivity of 80%, it improved to 91% when combined. You don't need to do both procedures at the same time, but at least you should have the skills and provision to perform EUSB as well. And there are circumstances when patients can't tolerate EBUS. For example, the patients who have a poor respiratory reserve or they have respiratory failure, and you do want to get the tissue diagnosis. So you are not putting the scope into trachea, instead you are putting into esophagus. So there is less risk of desaturation, and patients usually tolerate a scope into the esophagus better than trachea. There is no cuff reflex as well. And there are some lymph nodes, for example, station 2L and 4L can be accessed better with the EUSB instead of EBUS. And there are some patients who have got brain mets and they have raised intracranial pressure. You don't want them to cough too much during EBUS, so you can perform EUSB instead, and it is generally better tolerated. Next, I come to the endobronchial lesions. So if there are exophytic tumors usually, so this is a conventional bronchoscope. It has been there for several decades now that we see the tumor in the endobronchial T and biopsy it under our vision, but the biopsy size is small, and there is a significant failure rate, I mean, up to 40 to 30% in some series. So tissue has been the issue. There has been a boom in research to create more medicines for lung cancer treatment, as you all know, and we are usually asked to provide more and good quality tissue for more molecular analysis of these patients so that we can optimize their treatments. So this is cryobiopsy equipment in which there is a compressed carbon dioxide in this cylinder, and it works by Joule-Thomson effect. The compressed gas is released at the tip of the probe, and this probe is inserted through the channel of the bronchoscope, and you go in and freeze like this. In this video, one of my patients, so that is the endobronchial tumor, we are freezing the tumor and bringing the whole bronchoscope out and block to get better samples. And you can see upper photo is of the conventional bronchoscope, and below photo is from cryobiopsy. You can see the tissue sample is 10 times bigger than the conventional bronchoscope. So there are some better modalities now which have become available. So this is not that this practice is new. It has been studied in randomized controlled trial in January involving 600 patients, where they randomized about 593 patients equally into conventional forceps biopsy versus a cryobiopsy. As you can see, the diagnostic rate overall is up to 95% with cryoprobe and 85% with forceps. So you are improving the not only the diagnosis by 10%. And this diagnostic rate for cryobiopsy is the highest rate observed for any single sampling technique in bronchoscopy. So even EBUS does not reach 95% most of the time. And there is no increased risk of bleeding, whether you use forceps or cryoprobe. That has been proven as well. So we did a similar case studies, and this time we are not only looking for diagnostic yield, but also for molecular testing for these patients at Glenfield Hospital, Leicester. So we took 32 cryobiopsies from August 2017 to August 2018 under moderate sedation, and our diagnostic yield was 91%. Only one patient out of all these was non-diagnostic and required CT-guided lung biopsy. And one had no further procedure due to clinical deterioration. So this was the first study where we showed that having cryobiopsy samples is better for molecular testing. And so our pathologists were very happy with us. And there was no increased risk of bleeding. There was no case of severe bleeding when we used the cryoprobes. With the advent of lung cancer screening, and we are performing more and more CT scans and finding incidental lung nodules, so peripheral pulmonary lesions, you will face more and more in future, and some of them are very difficult to access by the conventional methods. So we have got a radial EBUS in this radial probe is introduced into the Perkin channel of the usual bronchoscope, and then it is taken to the target lesion under fluoroscopic guidance, and you can get usually 360-degree ultrasonic view of the lesion. But this is not a live procedure. You put the sheath there, and then you can put your forceps, brush, biopsy, etc. To take samples of form. But usually for radial EBUS, our criteria is that the patient should have a bronchus sign, which means there is a bronchus leading to the lesion, and also the lesion must be more than 2 centimeters. Otherwise, the diagnostic rate is very low. So we have seen sensitivity of radial EBUS up to 60 to 70%. And then the question arises, why not we just use CT-guided lung biopsy for these patients? So on this side, you can see that there are 31 studies on radial EBUS and 14 studies on CT-guided lung biopsy. So there are pros and cons. For pool sensitivity or pickup rate by radial EBUS is 69%, as compared to CT-guided lung biopsy, which is 94%. So definitely CT-guided biopsies are much better than radial EBUS, where we can perform them. But on the other hand, and the risk of pneumothorax or any significant bleeding is far way below CT-guided lung biopsies if we are using radial EBUS. And we can improve the radial EBUS yield further. We have started having ultra-thin bronchoscope. Usually the outer diameter of usual bronchoscope is 6 millimeter with working channel of about 2.5 millimeter, but now we are getting very thin bronchoscope with 3 millimeter external diameter and 1.7 millimeter working channel, and can go to the lesion itself. We can use virtual bronchoscopic navigation as well to help us guide to the lesion, but this is an expensive system. But it has been shown that if we use navigation bronchoscope, you can improve your yield further. There is another interesting technique, which is bronchoscopic transparenchymal nodule access, again from Germany, Professor Hurst's group. So if you don't have bronchus sign, there's a nodule where there is no bronchus going. You can't have any bronchoscope. You can't put radial EBUS or even thin bronchoscope. So in these patients, they have even created a small hole into the bronchial wall and made a tunnel through it and put a sheath through there, and then through that sheath you can put your biopsy forceps and brush biopsies, etc., and take samples. You will say this is quite traumatic procedure, but there is no risk of pneumothorax or death in this scenario. So this is bronchoscopic transparenchymal nodule access. Basically, they are reaching the nodule by going through the parenchyma of the lung. So an interesting technique, this one. So if I come across these patients who have got less than 2 centimeter diameter and they are not accessible through the airways, we can't perform radial EBUS. We usually go for CT-guided lung biopsy, but 25 to 30% false negative rate, and with the risk of pneumothorax up to 20 to 30% usually. Otherwise, you could go for bronchoscopic transparenchymal nodule access. This technique is not widely available, but watch this space. This is very important. This is close to my heart, that pulmonologists have been only concentrated on diagnostic process of the lung cancer, but here we are combining diagnostic and therapeutic process here. So this is a work by Kelvin Lau from Barts, London, 30 patients who had nodule less than 30 millimeter in size, and they were not fit either for surgery or stereotactic radiation therapy. So these were the patients where they, with the help of navigation bronchoscope and cone beam CT scan, they have gone and made the diagnosis of these nodules, and at the same time they applied the microwave ablation to burn these tumors. So they have, in this series, it is a trial in 2 centers, and they have proven that 100% success rate in this patient, to not only to diagnose but treat. So it is a multimodality process in which you can diagnose, even stage, you can do EBUS at the same time through EBUS, and then treat at the same time. So this will be interesting. For example, in this patient, there is a 9 millimeter nodule in the left upper lobe. So the catheter with cone beam CT guidance has gone to there. So the microwave ablation has been applied. So this is the coronal glass opacities around it. And CT scan 1 month later, the nodule has disappeared, left just with consolidation. So this is interesting as well. Then we have got ablative modalities for central liver tumors, several techniques, organ pulmonary coagulation, cryotherapy, electrocautery, laser. We use laser. Stents are evolving, and we have got 3D printed stents, drug-eluted stents for patients who have got central airway tumors. Medical spectroscopy is close to my heart, where you can not only drain the fluid, but diagnose by taking biopsies and also perform good draw. So diagnosis and treatment in the same setting. Lung cancer screening is up there. So 2 important randomized controlled trials, National Lung Cancer Screening Trial, 53,000 patients with lung cancer screening at 1 year, 2 years, and 3 years for 3 years. And they found that there's 20% reduction in mortality really in America. This is a nearly 12, 13 years old study. And then research study, but Belgium study, nearly 16,000 patients, and they showed 24% reduction in mortality in men and 33% in men. Here they did CT scans at 1 year, 3 years, and 5.5 years. And number needed to treat was 320 in the NSLT. And there's a meta-analysis of nearly 100,000 patients. Can you imagine? 100,000 patients, there's a meta-analysis. And they say that it is an effective screening tool. And the number needed to treat is around 265 when you pool all these studies. So cost effectiveness of lung cancer screening is much better than breast cancer and colorectal cancer. Really, if you look at the numbers, number needed to screen, if you have to find one breast cancer, you have to perform anything between 645 to 1,724 mammograms to pick one breast cancer. Whereas in lung cancer, really, about 250 to 65 scans you need to perform to pick up one lung cancer. Usually you pick them at early stage, 70% of the time. And they undergo curative intent treatment. So this has not been taken over by many governments really. It is very sad that this research has been going on over the last 3 decades, but it has not been taken over. But in UK, they have started, in USA, Poland, etc. It is coming up. Even there are private companies in London who are charging £700 just to do lung cancer screen scans and lung health check, etc. So I have said many things about many fancy things, interventional things, and the role of the pulmonologist is not only just to do intervention, but also try to do prevention as well. It is very important for each and every one of us that we work on smoking cessation advice and therapies. And this is if no one smokes, we will not be having this talk anyway. So it is important that we don't forget about the basics of our practice. So in summary, it is important to develop faster lung cancer pathways to manage lung cancer appropriately, to improve survival. A combination of multimodality techniques. We have to have more and more armamentarium in our hands to not only diagnose, but also treat the patient at the same time. Tissue is not more the issue. And encouraging results from lung cancer screening trials, and this should be implemented. And thank you very much for listening and for your time.
Thank you, Dr. Tufail. It was indeed a very informative talk, and I am sure that the audience will have many questions, but we will keep that to the end. Next speaker is Dr. Sundas Yahya. She will be talking to us about the role of stereotactic radiotherapy in lung cancer. Dr. Sundas is a consultant clinical oncologist and radiotherapy service lead at Queen Elizabeth Hospital, Birmingham. She did her MBBS from Khyber Medical College in 2002 and was trained in clinical oncology within West Midlands and obtained her CCST, MRCP, FRCR, and master's degree in clinical oncology from the University of Birmingham. She is a GMC accredited educational and clinical supervisor. She is trained to deliver systemic anti-cancer therapy and advanced radiotherapy employing CyberKnife and VMAT techniques. She is actively involved in breast and lung cancer clinical trials as a principal and co-investigator. She has been awarded RCR Cyclotron Fellowship to learn about proton therapy from University of Florida Health Proton Therapy Institute 2016 and RCR International Traveling Fellowship to support oncology education and training in low and middle income countries and support SABR and VMAT techniques development at Shaukat Khanum, Lahore. She also delivered the inaugural FRCR mock exam in Pakistan in 2019. So along with working outside, she has done a lot for development of this field in our country as well. So welcome, Dr. Sundas.
Very much. Assalamu alaikum, and I'm really privileged to come here, and I think life has come a complete circle, starting from here and then coming back, sharing all the knowledge that I have learned over the years. Sharing it with my peers gives me immense pleasure. So I've only got 20 minutes, but I'm just going to take you quickly through stereotactic radiotherapy in lung cancer. Just following on from what Dr. Tafel said, for small tumors, the stereotactic ablative radiotherapy has taken on big time, and particularly in patients where you can't really have the diagnostics in terms of tissue histology. This is a very, very good technique for local tumor control. So I'm going to try to cover literature review, particularly focusing on peripheral, central, and ultracentral lesions. We'll have a comparison between stereotactic ablative radiotherapy versus standard fractionation. How do we compare it to surgical outcomes? How do we select the patients? And then the most important strategy within stereotactic ablative radiotherapy is your organs at risks. How would you define SABR? What are the treatment, delivery, and verification challenges? How do you follow up these patients? Because obviously there's no surgical cutting involved. So, how would you know that the treatment has worked? What are the special considerations, particularly in lung cancer, because it has, come a long way, particularly, with your immunotherapy and with your targeted therapy. And obviously, the learning comes from research and trials. So, we need to be aware of those as well. So what is SABR? SABR, or SBRT, is stereotactic ablative radiotherapy. It's very precise radiotherapy given with very small margins. So particularly when we're talking about extracranial treatment, we are talking about margins which are 5 to 7 millimeters from your GTV, which is a gross tumor volume, to your PTV. And basically, you're delivering a very big dose of radiotherapy in a very small number of sessions, typically less than 8 or 8. Lung SABR has been established as a very good treatment option, particularly for stage 1 and 2A. Your typical tumor size maximum is about 5 centimeters. It has been shown to offer good local control, improve survival. Not sure about it, but clearly people have been living longer. There is a potential of better quality of life as well, because clearly, as I said, there is no cutting involved, so there is no downtime for the patient. It is minimally invasive, but there are very important characteristics. Your motion management, obviously, your breathing, your tumor is moving up and down. You have to take that into account. You've got very, very steep dose gradients, and I'll show you later on how that is very important, particularly when it is quite close to your organs at risk. Accurate targeting. Again, cone beam CT scans are very important, because you are giving a very high dose of radiotherapy over a very small area. These are very small volumes, and just like Dr. Tafel said, you are looking at tumors, and with the current diagnostic imaging, you are picking up nodules that are 5 millimeters. So, the smallest I've treated, like literally last week, was 7 millimeters. So more and more is possible, and clearly you're giving high dose per fraction. So when we are actually reviewing the literature, one has to bear in mind that all these therapies, just like IMRT, has evolved from retrospective studies. So there is a paucity of evidence for your randomized control trials. SABR is not a new technique. Gaskell evolved this from intracranial lesions back in the 1970s, and it is during the developments in the last few years that the extracranial SABR has taken off. The importance of that in lung cancer and the lung tissue is that you've got the parallel structure. So what you have to bear in mind is that if you've got central tumors, you've got the arc of radiotherapy that's going round through, and you've got two, parallel structures, how are you going to save the opposite lung? That's the most important, consideration. We do prescribe to the isodose line, that would be your planning target volume. So within the tumor, your dose can be as high as 185% to your prescribed dose. So again, a very important treatment considerations, because you don't want your high dose to be in the, close to your normal structures. And you need to make sure that your dose is homogeneous within your PTV. So looking at the trials, comparing with standard fractionation, the SPACE trial and the CHISEL trial are the only two trials that are randomized controlled trials. I've not actually included any of the retrospective studies, but the SPACE trial was a non-inferiority trial, and basically it compared SABR versus standard fractionation, and you had SABR fractionation up to 8 fractions, and the standard arm used up to 33 grays, 66 in 33 gray or 50 in 20 gray fractionation. And it actually showed that there was no difference in your overall survival and progression-free survival. The CHISEL trial was also a comparison between the SABR and the radiotherapy standard fractionation, but it actually showed superior local control compared to conventional radiotherapy, and your local control rates were as high as 89%. But you have to take it with a pinch of salt, because your sample size was really small. But it does provide you with some good evidence. I'm not going to go into the detail of all the studies, but essentially what I wanted to show you was just have a look at this 24 months mark. So I've picked up a range of studies in the meta-analysis, and basically your overall survival at 24 months is still about 60 above 60%. Now that is good in lung cancer. When you actually look at the overall survival in all stages of lung cancer, we've not really moved from above 3 to 5%. And then this is the most important thing. So when you are actually consenting the patients, we actually talk about local control. We've not yet started talking about overall survival. And so for smaller tumors, less than 2 centimeters, I normally code it is still about over 90%. But even for up to 2 T2 tumors, at 60 months, your local control is actually, above 80%, which I think is quite good in lung cancer. And then, so peripheral SABRs, we have become very comfortable, it's not really a big deal. And therefore now we are striving to try and treat the central and the ultracentral lesions. And I'm just going to come to the definitions of it, but I just wanted to show you some data. We are very, very, very concerned about tumors that lie within 2 centimeters of the proximal bronchial tree. And it is because of your toxicities. So again, these are all randomized control trial, and this is the latest trial that's published, the HILES trial, which published a few months ago. And basically, we had 56 grain, 8 fractions, and it was prescribed to 67% of the isodoses. But what really concerned was this grade 5 toxicity in 10 patients. Now, this is totally unacceptable, particularly in this day and age. And when you talk about grade 5 toxicity, you're talking about massive hemoptysis causing death, tracheal perforations, or even vascular rupture. So clearly, this is the area that requires more consideration. When you compare SBRT with surgery, again, randomized controlled trials are only 3, Roselle, STARS, and Z4099. Unfortunately, all of these trials were closed prematurely because of the scarce accrual. So what they did then was they did a pooled analysis of the Roselle and STARS trial, and they showed that there was reduction in morbidity and there was no inferiority of the overall survival. So, you have to bear in mind that these are all non-inferiority trials. And the comparison was between the SBRT versus lobectomy. So your 3-year overall survival rate of the pooled analysis was actually in favor of SBRT, 95% versus 79%. But again, as I said, small sample size. And the other thing that you always have to bear in mind is that for this patients that are selected for surgery are younger patients, they've got good lung function, and their operative mortality is, standard is about 1.5%. So there is already a selection bias in that. So you obviously have to take that into account. Whereas for the SABRE treatment, these will be smaller tumors. So, when you're looking at these trials, always look at it, critically. Just don't go on these numbers. You have to dig deep into the trial. Sabertooth was a really good trial, started off by Kevin Franks from Leeds, but unfortunately, again, did not take off. It was a phase 2 feasibility study, really good trial design, but unfortunately had to be closed prematurely at phase 2 because of the poor accrual, just because we've just become so comfortable in treating, smaller lung cancers that, offering a patient then surgery, the take-up rate was really bad. So how do we select the patients? So, sitting in the MDT, like, Dr. Tafel said, and you've got a tumor that is growing on serial imaging, or if it is PET positive, less than 5 centimeters, and the lung function is really poor. So you've got an FEV1 of, less than a liter. The surgeon will just wash their hands and say, well, actually, I'm not going near this patient. So the next option is, okay, can we offer stereotactic ablative radiotherapy? And so what we ask the radiologist then is, where is the tumor located? Any tumor that is located within 2 centimeters of the bifurcation of the carina is a no-go zone. You should only be treating it either in the context of a clinical trial, or if you have got a lot of experience. So we've been doing SABRE for nearly 9 years now in UK. So we've got a lot of experience. But even for the central lesions, you do require sort of, significant peer review and consensus amongst your team. So basically what you do is you mark up your proximal bronchial tree to the bifurcation of the second order bronchus, and then you grow a margin of 2 centimeters. So this is your no-fly zone. So basically you ask your radiologist, is it falling within the no-fly zone? And if the answer is yes, your answer is no, I cannot deliver SABRE safely. So there are certain definitions that obviously form the basis of, lung SABRE. So as I just said, you've got a peripheral lesion, which includes all the tumors arising from the lung parenchyma, at least 2 centimeters from the proximal bronchial tree. And then we clearly require definitions for the central and the ultracentral lesions as well. So the most commonly used definition is the IASLC, which define the central lesions within the 2 centimeters. And again, as I said, because we started becoming comfortable of the lesions that just fell within the 2 centimeters of the proximal bronchial tree and the mediastinal and pericardial pleura and brachial plexus, we required a further definition of what ultracentral is. So this is the Nordic HILES trial that I just presented the data on earlier, which defined the ultracentral zone, which is any GTV that falls within the proximal bronchial tree, overlapping the trachea and the main bronchus. So how do we define and what are the nomenclature that we use for stereotactic ablative radiotherapy? So your GTV is the radiologically visible tumor in the lung, and your MGTV is the mobile GTV. That is the tumor volume obtained within the 4D CT. Now I know, and particularly when I was working with Shaukat Khanum to try and establish this treatment, we knew that we didn't have 4D CT, and in that case, you take serial imaging using a 3D imaging in inhale and exhale volumes, and then you've got lots and lots and lots of images that actually shows you the tumor motion, and then you combine them to try and get the envelope of the tumor motion. There is no clinical target volume. So your mobile GTV is your CTV, and then your MGTV to PTV is your departmental protocols. So your departmental protocols are basically dictated by your motion when the patient is actually on the bed. So that can vary from anywhere. So our tightest margin is 5 mils. Maximum is about 7 millimeters. When you go to about 1 centimeters, that starts to worry us, because that's means that the department needs to work harder to try and tighten their margins. So when you're marking the organs at risk, if you're using planar, coplanar techniques, you can just mark a couple of centimeters from the top and to the bottom of your PTV. But if you're treating with machines like CyberKnife, where the beam of radiotherapy can come from wherever, you have to mark the organs at risk within 15 centimeters, because you really don't know where the beam will traverse, and if you have got a hotspot in the path of the beam. And the other important thing is in reviewing the plan as well. You really need to have a look at the plan and look at the spikes that these machines form, because you could be having a beam of radiotherapy that's coming from your eye, and you don't know about it because you've not actually switched on the proper parameters. Tumor motion and motion restriction is the most important aspect of SABR treatment, and it is most important for the mid lobe and the lower lobe tumors. Some of the tumors that move a lot, by definition more than 1 centimeter, you can use techniques like abdominal compression, respiratory gating, coached respiration, and active breathing control. We have all of these 3 techniques that we use at QE. We haven't got the active breathing control, but again, that is where colleagues come very handy. You've got, you've got phone a friend, you've scanned a difficult patient, you've done a centimeter mobility tumor, and you've tried, abdominal compression, still not working. You phone a friend to say, can you take this on? So there's a lot of sort of, referring the patients between the centers as well if they've got a better technique. So never compromise on quality. Dose fractionation most commonly used is 54 grain 3 fractions, 55 grain in 5 fractions, or 60 grain 8 fractions. This is a peripheral tumor, but it is abutting the rib. So the risk of rib fracture is about 30 to 50%. So I don't want to give a very high dose, because 54 grain 3 is 18 gray per fraction. So I would prescribe 55 grain 5 fractions. Even then, the risk of rib fracture is about 30%, and you will consent the patient for it. So these are the most commonly used fractionations within UK. For the peripheral tumors. When you come to the central tumors, you obviously want to fractionate more. And we've actually got a couple of trials running at the moment. So we've got oligo-rare trial, which is using 48 gray in 4 fractions. In North America and Europe, you can safely treat with 60 gray in 8 fractions. And that is mostly dictated by the vessel wall tolerance. But for the ultracentral lesions, again, has to be treated in the context of a clinical trial, but the most commonly used fractionation again is 60 gray in 8 fractions, and 16-15 has been deemed the most safe in the German studies so far. Side effects, again, sorry about the busy table, but essentially what I wanted to show was that, again, when I was helping Shaukat Khanum, these are the kind of graphs and sort of, tables that you have to produce with your physicists, because you have to give them the goals. As clinicians, you need to tell them what is the tolerance of an organ that beyond that you're not going to accept a plan. So for example, if you are close to the great vessels, you're half a cc. If you've already reached up to 53 gray, you're not going to go beyond that, because you know that you will actually blow a hole in the vessel. So, your risk, you are falling into high risk category for your toxicity. So, you've got grade 3 aneurysms and all of that. Chest wall, this is kind of an arbitrary measure, to be honest, because if you have got a peripheral lesion, there is no way that you're going to be able to avoid the chest wall. So even when you are beyond 39 gray, I would say, what's the worst thing that will happen? You're going to get a rib fracture. Yeah, fine. The patient has consented for it. They will get some chest wall pain when they're breathing, but they heal. If you don't treat it, obviously the tumor will grow and they will get chest wall invasion. They will get pain anyway. So again, it's a trade-off. Treatment delivery and verification, again, extremely important, particularly if you are developing this technique, the clinician has to be present on day 0. There are lots of technical considerations. So on patient setup, day 0 verification is very important. So this is the tumor that I had marked. But when the patient came and we wanted to match him on day 1, can you see the tumor has actually moved? Again, it's a very small tumor, so it's a centimeter tumor. But the image quality, you can see the 4D CT and the cone beam CT scan is not great. So that is another consideration. Are you able to see the tumor? And that is the problem when you're treating cystic lesions or lesions that haven't got enough solid components. So the matching is very important. So in this patient, you cannot treat. So unfortunately, you're going to have to repeat the cycle again. It's going to be a replan and a rescan and a replan. I'm just going to quickly run this movie just to show you, so this is a 4D CT scan. This is how we've obtained it. And basically, the most important thing that I wanted to show you in this is tumor motion. So when you have got central tumors like that, they don't move much, so here, you just go from the CTV to the PTV. This is not saber treatment, but I just wanted to show you the principle of this because, as you may have picked up already, that this is actually a central tumor. But if you have got tumors that are sitting there, these are the ones that actually will cause you problems. So, you really have to match that. So we have a technical saber MDT. So, once we've planned and, signed off the plans, our technical leads sit down together. We previously used to sit with them, but because we've now got experience, they can just do it on their own. And they then identify patients of whom the verification needs to be done on a 4D CT scan. So if you have got lower lobe tumors, your day 0 verification will be on a 4D CT scan. But then subsequently, if you are able to see it better, you can just go onto a cone beam CT scan. But for the upper zone tumors, if they're not moving very much, you can just do verification with cone beam CT scan. How do we follow up these patients? Obviously, you've delivered the treatment. You must tell the patient that radiotherapy takes time to work. You're not going to have an instant, there's no cutting involved. So it's not that the shadow will disappear because, it comes as a big disappointment to the patient when they come back and they see the scan. But this is actually a very good result. In 3 months' time, you scan them again, the tumor has started to disintegrate. It's already looking smaller, but see what I have done. I've actually damaged the lung. Okay, now again, if you already are treating patients that are on the lower respiratory reserve, make sure that you have done their lung function before. And if their shortness of breath is not settling within 3 to 6 months, you should be repeating the lung function tests because they can develop significant pneumonitis. And in the lower lobes, a little bit of tip off, into the pneumonitis can have a real bad effect on the quality of life. So very briefly talking about the ultracentral lesions, the reason why this is important is that there is direct correlation of your toxicity to the dose to the airway. And basically, the grade 5 toxicity, which is, death and worse, particularly if you are using concomitant medications. So, if you've got patients who are on osimertinib, for example, or even immunotherapy, you are actually multiplying the effects of radiotherapy because these are all radiosensitizers. I mean, obviously, we haven't got head-to-head trials at the moment or the results of those of concomitant treatments with radiotherapy. But we know that if you have got any dose that is greater than 140 gray, and just remember going back, I said that within your PTV, your dose can be as high as 185% of your prescribed dose. So basically, you've got 150 gray within the tumor. You are actually going to blow a hole in the trachea. So that's why it's extremely important to be mindful. What about, other patients that have got background lung damage? Are you going to exclude them from this really good treatment? And again, the answer is that if you have got patients with interstitial lung disease, you have to be cautious. You can still offer it, but if you have got patients with IPF, the mortality can be as high as 33%. So it's not justifiable. Okay, so again, with experience, you can super select patients who have got volume of less than 2 centimeters. And then, what you can do is you can put very strict constraints. So your V20 of less than 10%. And if you go beyond that, your risk of mortality is very, very high. So, I would not go near that patient. And again, sometimes you cannot see that when you've actually consented the patient or unless you've planned it. So again, that is an important thing as well, that when you are actually seeing the patients, don't get them to raise their expectations too high, because you may not be able to deliver the treatment safely. And we have done that on a few occasions. So I just wanted to very briefly touch on this. Again, lung cancer has come a long way. We are testing for seven or 9 mutations now. So, you've got BRAF, you've got RET, MET, EGFR are all old ones. And then you've got these patients, and then you've got one tumor that starts to progress. What do you do with them? You don't want to change the treatment. So we are in Raymond trial, for example, that I'm leading on. We would offer them radiofrequency ablation or surgery, or even say, but what do you do with the treatment then? I mean, you've got disease that's held stable elsewhere. Do you actually stop the treatment? Or do you continue? We don't know the answer to. So you would just go to the path of least damage. We do then stop the treatment a week before the radiotherapy and restart a week after. And we're just going to very briefly talk about the trials that is ongoing. So Lung Tech is again a very good trial, which is looking at inoperably centrally located tumor. It is accruing at the moment. HALT trial was the one that was run by Fiona McDonald, who is our SABR consortium lead from the Marsden, and basically
really sorry, we are just
yeah, okay,
short of time.
yeah, sorry,
I'm really sorry.
No, it's okay. So I think in conclusion, ultracentral lesions, treat in the context of the trial, and then familiarize yourself with the toxicity. Thank you.
Thank you much, Dr. Sanders. Sorry to rushing you in the end. I'm especially privileged and honored to introduce our next speaker. That is Dr. Solit Fatmi. He's going to talk to us about surgical treatment of lung cancers. He's a professor of cardiothoracic surgery and chief of cardiac thoracic surgery at Aga Khan Hospital. He's a diplomat, American Board of Thoracic Surgery and General Surgery. He has got over 200 publications and has a US patent. And we are really happy. He is a well-known figure in minimally invasive video-assisted thoracoscopic surgeries. I'm very honored to again introduce him. And I understand that this is the first time that he has been in Peshawar. So welcome, Dr. Sadi.
So thank you very much. It's a privilege to be at Shaukat Khanum. It's always been a privilege to go to Lahore. And this is the first time in Peshawar, and it's been a great 24 hours. So, ladies and gentlemen, Assalamu alaikum. My topic is surgical treatment of lung cancers. Lung cancer, as you know, is the leading cause of cancer death in the world. However, things have evolved over the last 20 years. 20 years ago, it was all about surgery and chemotherapy and radiation. But now we are talking about surgery versus stereotactic radiotherapy, as Sundar said. We're talking about ablation of tumors with bronchoscopy, as Tofel said. But surgery has remained as the cornerstone of lung cancers. I have no disclosures. And it continues to evolve, but it remains as the treatment for lung cancer, it's the gold standard. Everything else is compared with surgery to see if the treatment works or not. In spite of all the advancements, yet 37% of the lung tumors that are diagnosed will be treated ultimately with surgery. And I will go to a different lens, but first let's talk about what are the aims of surgery. There are three aims: the curability of any surgery, curability, resectability, and operability. The curability is defined by the medical oncologist. Not they come to me and I'm not going to be the person and say it. Nowadays, it's you have to have a multidisciplinary meetings. If you don't have it in your hospitals, you should start that, because unless you have that, it will be just like one person deciding everything. And it's not, it doesn't happen like this anymore, not in 2023. So you have to define curability by medical oncology. Usually it's through PET scan and some other ways, and after the pathology. So the curability, once they decide, yes, this is not distantly metastatic, this is something which is surgically curable, that's when the pulmonologist and the surgeons come into play. The pulmonologists then decide whether, along with the surgeons, they decide whether this person is actually operable. He's not going to, his lungs are good enough to be operated or not. All these years, we have talked about FEV1, and we talked about lung function tests and DLCOs. However, there is enough data now, and even my own, one of my grants proved that a simple 2 flights of stairs is as good as an FEV1 of above 50%. So that is one thing which has evolved over a period of time. We can, with anesthesia, with critical care, with the way we work with the toilet bronchoscopies, you can operate on a low FEV1 patients also. So the operability part, especially with the cardiac and with the rest of the organs, it has become more and more patients are operable than before. And then comes to the surgeon. And I define the resectability. To be very honest, everything is resectable. Everything. It all depends upon how far you want to go to, whether that patient will have a meaningful life after that resection or not. So that is where we stand, and that's what we do. So in each treatment, there are a few things that one should have. One should define oncological and anatomical aims. They should be ideally without morbidity and mortality. They should have the least functional impact. They should have the best quality of life, preserving long-term survival and anticipating treatment options. If you look at this, if you look at this, isko kaise karna hai? If you look at this simple slide, okay. If you look at this slide, and if you see this stage depend on the 7th or the 8th staging, the stage 1 is the best, where you have the survival of 70 to 90%. Stage 2 is about 56 to 65%. But then those stages which are way down, these stages have also evolved over a period of time, with not just surgery, because of the immunotherapy and other modalities that have come in. And that's where what Dr. Sundar described about the ones which are inoperable also can play a role. I would briefly touch into the types of operations so that the nurses and the students can understand. There's something called a wedge resection. You just fire a staple on either side and take it out. You can do a segmental resection when you are taking out the segmental artery. You can do a lobectomy, and you can do a complete pneumonectomy, which means removing the entire lung. Very straightforward. The approaches towards that is a conventional posterolateral thoracotomy. Most of you have seen that. Then there is video-assisted thoracoscopy, and you can do easily wedge resections, segmentectomy, and especially straightforward lobectomies with this. And then you have something like this, which is robotics. I have not done this because I'm way old now. So the ones who are coming up, if they don't know something like this, they'll be left behind. So the robotics is coming in, and it's actually a beautiful way of resecting a lung without creating much morbidity and mortality. So I'll go through briefly about the surgical treatment of early stages of lung cancer, and then go over multiple times with different stages. So the stage 1 tumors are few. Less than 25% of the lung cancers are stage 1 tumors. How do we identify that? Is the first speaker, Tufel, mentioned about low-dose CT. That is the thing now in 2023. If your hospital, especially Shaukat Khanum, wants to promote treatment of lung cancers, they should promote low-dose CT. One thing, low-dose CT, because it works out, and you'll be able to identify stage 1 cancers. So stage 1s are something like that. I'm not going to go into detail, less than 2 centimeters or less than 3 centimeters all around, but they should, the key is they should have a visceral pleura all around it. So the open lobectomy with a complete lymph node dissection is the gold standard. Now, lobectomy now can be done with VATS, with robots. However, the gold standard still stays as an open lobectomy because that's the cure. You will remove it. The key is the lymph node dissection. You will not go in there and do a cancer operation without clearing the entire mediastinum. It will not be a mediastinal nodal sampling. You will remove level 2, level 4, level 5, level 7, level 8, level 9, all lymph nodes. So complete lymph node dissection is the key. If you can do that, that's where you achieve the 76 to 95% survivals. However, there have been issues. People have argued about minimally invasive. People have argued about why remove the entire lobe when you can remove something else. When I was a surgery resident in the 90s, there was a study from the lung survival group, which was way before even I became a resident. And they proved at that time that if you do a segmentectomy, it's an inferior operation as compared to a lobectomy because of the recurrence. There was an 11% recurrence with the segmentectomy as compared to 4% recurrence if you do a lobectomy. People continued with that. How are they as the decades progressed, as the iPhone became from iPhone 3 to iPhone 14 plus, the cancer treatment also progressed. And people questioned, why not segmentectomy in this day and age? So the key was that the margins have to be complete and you have to remove the entire tumor. So they looked at the survivals afterwards and they were reasonably comparable. But what they did was they had technical challenges. So what they did was they started using fluoroscopic, endoscopic ways, physical X-ray markings, and 3D reconstruction of segmental vessels. That's all in place. So what they have done is, if you want to do a segmentectomy, the preoperative planning will require a CT scan and a 3D reconstruction. You will have a marking with either bronchoscopy or radiology, and then you will have all of these dyes which can actually identify that. And with this, you can do a video-assisted thoracoscopy open or do a robotics, especially video-assisted thoracoscopy. How often we have employed any of this at AKU? No, never. How often we have employed this? Always. We always do a 3D reconstruction, and obviously we discuss them in the multi-disciplinary meeting so that we decide whether I can actually do a video-assisted thoracoscopy. And this is especially true for superior segment of the lower lobes. The rest of the segments, I can't do the segmentectomy properly. Okay, that's my own drawback. As I told you, I grew up in an era where there was just developing all of this. Why do I do this? Why do I say this? Because I cannot identify the segmental vessels for the apical segment, anterior segment, and the posterior segment. I can identify the vessels, but I can't identify the margins, the margin of this segment to the other segment. So I have preferred doing only segmentectomies in the lower lobes. And the rest, either you do a wide wedge if they cannot tolerate a big procedure, or you do a simple lobectomy. So for simple T1 and T1, this is level 1. Segmentectomy or lobectomy for any of these, which are less than 2 centimeters, you will do a complete lymph node dissection always, irrespective whether you can identify lymph nodes or not. And the approaches are this. For T1C to T2A, again, the same thing, lobectomy with complete lymph node dissection, and the same thing. Now, remember, there's one thing which people always argue. Would you do a mediastinoscopy or a VATS lymph node biopsy in a stage 1 cancers? In a stage 1 cancers, the chances of lymph nodes, if their PET is negative, are almost approaching less than 5%. So the recommendation currently is you don't want to biopsy the stage 1 lymph nodes prior to going for surgery. As far as the resectable stage 2, excluding the T3 tumors, T3 and 0. I will go through the T3 and 0. Stage 2, the treatment is straightforward again. Multidisciplinary, preoperative multimodality lymph node dissection assessment. So in this one, everybody gets a PET scan. As soon as there is a diagnosis of lung cancer or with a biopsy or assumption of a lung cancer, everybody gets a PET scan in 2023. Without a PET scan, going for surgery is not 2023. So everybody gets a PET scan and everybody should get a lymph node assessment. We are selective, okay, at AKU. However, there's University of Chicago who biopsies every lymph node above a stage 1, whether you can identify them on PET scan or not. We have been selective. If your lymph nodes are less than 1 centimeter and they are not highlighting on PET scan, I don't biopsy them, especially for stage 2. For anyone above stage 2, I will biopsy all of them. But even if you have to biopsy them, instead of a mediastinoscopy, we do VATS. But that is something which is recommended. If there is a question mark about the lymph node, should biopsy them. And then you go with the surgery, which is surgery, followed by, in all of these patients nowadays, everybody should be recommended an adjuvant chemotherapy. Chemo or radiation, depending upon where they are. But the chemotherapy is the key after the surgery. For stage 1, no chemotherapy. For stage 2, some people may argue about the stage 1 too, but for the stage 2, it's adjuvant is chemotherapy. Then what is the CT3? Okay, the stage T3 non-small lung cancer. The T3 tumors are these: high volume tumors between 5 and 7 centimeters. There are multiple tumor nodules in the same lobe. Now remember, previously, if you had 2 nodules, 2 tumors in the same lobe, they were considered as T4 lesions. Okay. Now they both are considered as T3. Okay. So they both are in the same lobe. They're 2 separate areas. They're T3. Tumors which infiltrate the chest wall, including the Pencost, are also T3, and which involves the phrenic nerve and the pericardium are also T3. They're not T4. So if you have a chest wall, if a mass which is invading the chest wall, which is this, which is T3, if the hilar lymph nodes are less likely, but you will biopsy them, they're most likely candidates for en bloc resection. And they will be treated afterwards with an adjuvant chemotherapy and radiation. There are centers who will do a neoadjuvant chemotherapy, 2 cycles followed by surgery, followed by 4 more cycles and radiotherapy. We at AKU have followed a consensus that if it is resectable, we will go for an en bloc resection right from the get-go, followed by chemotherapy and radiation. I always, and I recommend this to all young budding surgeons, if there are any, to put the staples all around your margins so that the radiation oncologist would know where they have to give the most radiation. If you just resect the entire lobe, and let's say it was close to the phrenic nerve, and you don't put some staples there is no way to predict where it was. And on a on a post-op CT, you will not be able to figure it out. So I would do this. So the factors which enhance survival is the chest wall invasion, resection, and lymph nodes. Now, what about the chest wall invasion? Mayo Clinic believes that if it is only involving the parietal pleura, just remove the parietal pleura. And that's it. That will take care of it, and followed by adjuvant chemotherapy and radiation. Most of the people don't believe in it, and I also don't believe in it. If it is attached to the parietal pleura, the tumor cells have already come close to the ribs. So you have to do an en bloc rib resection in order to have a complete margin. What about the Penco's tumor, which is right up there? And the Penco's tumor are amazing. They usually do not metastasize anywhere. The lymph nodes are, if they are negative, you can resect them also with the same thing. So if you have Penco's tumor or any of these chest wall tumors or less than 5 to 7, the treatment is surgery if it is doable. If questionable, do a chemotherapy, 2 cycles, followed by surgery, followed by chemotherapy and radiation. What about the T4 non-small cell lung cancer? Now, a few years ago, if you would have asked a decade ago, not a few years ago, a decade ago, and things have progressed in the decade, you would have asked, oh, T4, it's all gone, khatam. However, T4 tumors are also these. They're high volume tumors. They're separate tumors in other ipsilateral lobes. So previously, this was considered as a M1 in 2 different lobes, like right upper and right lower lobe. It was considered as M1 before. Now it's considered as T4. And central or hiatal tumors or tumors infiltrating the mediastinal structures, okay? So for them are, and most of the places which are high volume centers or places which do high tech surgeries, with the multimodality treatment, we recommend that we should give 2 cycles of chemotherapy, neoadjuvant, followed by reassessment. Over these years, we have had about 78, 79 of these. We have been able to do 14 of these. We opened 18, 4 of them we abandoned, and we have been able to do 14 such cases. And 2 of them had over 4 years survival. So it's not something I can write on because there are only 14 cases, but this is something which you can do. So for T4, this is the treatment. What about stage 3 lung cancers, locally advanced N2 disease? When I was a resident in the 90s, the N2 disease was considered as incurable, inoperable, khatam. However, again, 2023, the N2 disease is no longer incurable, okay? It's not, at least not something that you sign off, especially with the current immunotherapy. So with this disease, with the N2 disease, which is this stage 3A, the treatment is neoadjuvant chemotherapy, followed by video-assisted thoracoscopy, leading to different lymph node sampling, not just level 2 or level 4, different lymph node sampling. Histological confirmation that there is no cancer or cancer has died, and obviously they have got a PET scan before, and no metastases, you go in and actually do a lobectomy or a pneumonectomy followed by a complete lymph node dissection. So this is something which may be new to some of you. So remember, N2 disease is no longer doable. Can I take a couple of more minutes, please? Okay. So for surgery of N3 is not recommended at all. And for stage 4, now stage 4 is something which is considered as incurable, inoperable. However, there are few instances when it can be. So it has to be discussed in the multimodality meeting. For a stage 4 contralateral lobe tumor, now this is going beyond what most of you have learned in the books and stuff. This is latest. So if you have a contralateral lobe tumor, which means a right upper lobe tumor along with a left lower lobe tumor, and the person is absolutely fit with no other distant metastases, your lymph node dissection biopsies have been done, which shows no tumor, you can actually remove both of those. And previously, it was considered as a no-go. but this is actually doable. For isolated brain and adrenal mets, everybody knows that you can actually do a lobectomy followed by a cranial resection as well as an adrenal, which is doable. And the persons who are actually not controllable and they have metastatic site at the spine, you can actually do that too. But what about ones which have no control? What is the role of surgery in a metastatic, incurable, palliative treatment? Pleurodesis. Okay, that's number one. Number two is you can tap them. You can actually put in, do a wax and talc them, and then you will be able to take care of this with the breathlessness. And then there is a recuperative surgery, which is salvage surgery. You can go back and operate on them also a little later, but this is also very, very new. However, what is the last message which you can take home? That the lung cancer surgery is no longer the end of the life anymore. People with a stage 4 lung cancers with the current immunotherapy, they can live 5 years. Could you have imagined this in 2010? Impossible. They would have lived 6 months. Now they survive 5 years. With effective pulmonology treatments, with effective stereotactic and radiotherapy, with amazing immunotherapies, though expensive but doable, and with various approaches to surgery, lung cancer is no longer something to be dreaded about. It is doable, and surgery stays as the gold standard if it can be done. Thank you. And thank you very much.
Thank you, Dr. Saud Fatmi. Next, we are going to present thoracic oncology case by one of our fellows in radiation oncology, Dr. Rabita. In the interest of time, Rabita, can you finish this in 10 minutes, please? Very quickly. Thank you.
Bismillahirrahmanirrahim. I'm here to present a case of thoracic oncology, and I would invite the worthy panel for their expert opinion regarding the case. Thanks. So my patient is a 42-year-old male. He was businessman, smoker, and he was presented to us with chest pain for the last 4 months and dry cough for the last 4 months. So he had chest pain in the right upper side of the chest, which was gradual in onset, moderate in intensity, not referring or radiating to any side, and there were no associated symptoms apart from dry cough. Rest of the systemic inquiry remained unremarkable. There was no family history and there was no past history. So on examination, he had decreased air entry in the right upper lung and there were no added sounds, and rest of the systemic examination remained unremarkable. So a CT chest was done, which showed right upper lung cavitary lesion, and he was taking ATT for the last 4 days when he reported in walk-in clinic, which was stopped at that time. Bronchoscopy was done, and histopathology showed to have TTF1 positive, CK7 positive, and atypical cells favoring adenocarcinoma. So on PET CT, we had hypermetabolic right upper lobe cavitary mass with ipsilateral, hilar, and mediastinal lymph nodes. According to this, the stage was T3, N2, and M0. So right paratracheal node fine needle aspirates show metastatic carcinoma, and right upper lobe mass fine needle aspirates was positive for malignant cells. So at that stage time, it was T3, N2, and M0, that is stage 3B, and as multi-level station lymph nodes were positive, so MDT suggested for definitive concurrent chemoradiation with 60 grain 30 fractions with cisplatin-based doublet chemotherapy. When MRI brain was under process. So MRI brain showed a brain met that was solitary and in temporal lobe, RPA class 1. The plan of the treatment was to get molecular markers which showed EGFR positive and PDL1, which was 10% positive. So what should be the treatment?
Can you hear me? Yeah, so because this is PDL1 positive, certainly there's a lot of evidence about adjuvant nivolumab. So when you are offering concurrent chemoradiotherapy, within 42 days, you can commence them on nivolumab. Obviously, you have to take into consideration about the pneumonitis. I
Right.
think the other most important consideration that I actually wanted to share with colleagues is your lung cancer patients are not fit enough for cisplatin all the time. And one of the other regimens that you can actually use is paclitaxel carboplatin.
Yes.
It's a weekly regime. It's very well tolerated, and you hardly get any hospital inpatient admissions. And you hardly miss any treatments, because if you actually use platinum doublet, your cycle 4 is invariably missed in about 50 to 60% of the patients. Right. It's not very well tolerated at all, actually. So I think weekly chemotherapy is much better. And then you do an end of treatment scan,
Right.
in your final, and as long as you've got stable disease, you get them on nivolumab.
Right.
Okay.
Thank you. So as it had oligometastasis and we got EGFR mutation positive and PDL1 was low. So all patients with a sensitizing EGFR mutation should receive first line EGFR tyrosine kinase inhibitor, irrespective of clinical parameters. So osimertinib is a preferable first-line treatment option for a patient with classical activating EGFR mutation, which is exon 19 deletion. And this patient had exon 19 deletion as well, especially for patients with CNS metastases. So this patient also had CNS metastasis. So we started on osimertinib, 80 milligram per oral daily. And after a month of starting osimertinib, the patient started to have shortness of breath. CT pulmonary angiogram was shown, done, and showed bilateral segmental pulmonary embolism and below leg and popliteal DVT. So enoxaparin was given stat and discharged on oral rivaroxaban. Interim scan was done in July 23, and it showed partial treatment response by virtue of interval decrease in FDG avid right upper low cavitary mass and ipsilateral hilar and mediastinal lymph nodes. So I leave it to the panel for further discussion.
So I'm just going to add on that for concurrent chemoradiotherapy, your staging investigations, including your brain imaging, is must. So if you have identified brain metastases, you should never proceed with concurrent chemoradiotherapy,
Right.
particularly in a patient like this who had EGFR activating mutation. You actually want to treat their brain mets. So, if you have got, 1, 2, or even 3, as long as your volume of disease within the brain is up to 20 cc, you can actually offer them SRS and then get them onto osimertinib.
Right.
But you would never offer concurrent chemoradiotherapy in patients who have actually got active brain metastases.
Right. So we didn't go for concurrent chemoradiation. We started with osimertinib and then gave a single stereotactic radiosurgery dose of 24 gray to the patient. So after a month, a patient presented with shortness of breath, and on CT thorax, there was progressive disease evident by interval increase in the size of right upper lobe mass with development of few adjacent satellite nodules, and enlarged left supraclavicular lymph node and suspected ipsilateral lymphangitis carcinomatosis, and intermediate sub-centimeter hepatic segment 6 hypodensity with the correlation with multiparametric MRI suggested that it was a liver met. And left scapular spine lesion showed on bone scan that it was a bone met. So I leave it to the panel for further discussion.
I think that this is a surprise case for me as well. So that actually brings us to HALT trial that I was talking about earlier. So in oncogene addicted tumors, if you have got oligoprogressive disease, in the setting of the trial, you could have actually offered liver saber to that liver met and the scapular met as well. Outside of the trial, it's a bit tricky. You can get it through your Saber MDT to say, well, actually, the first thing you're obviously going to do is, check for the mutation resistance.
Exactly.
Okay, so you will do that. But then at the same time, if you've only got 2 areas, you can take it through your Saber MDT and say, well, actually, I've started on this treatment. Can you offer Saber? And we have actually done that.
Right.
Yeah.
So thank you so much. Thank you.
Thank you, Dr. Abeda. Do we have any questions for the speakers? Yes, Dr. Jamshed.
Assalamu alaikum. This is Jamshed from Shaukat Khanum, Peshawar. Thank you, Dr. Salat, to be here. I have a question for you. So I was just wondering, what is the role of metastasectomy in lung cancer, in lung? So if a patient is having from any other side, do you still consider, as you mentioned in your talk, that everything is resectable? So do you see for the origin of the cancer, or regardless of the origin, you will go for the resection? Thank you.
So you have to identify where the tumor has originated from. Let's say it's a germ cell tumor. You don't want to resect those germ cell tumors. Let's say they're lymphatic deposits. You don't want to do it. So you have to identify. So what the new thing is, first you want to figure it out whether it's curable or not. So their curables are gone. 1 and 2 are gone. So this we are talking about lung cancers metastatic to the spine, lung cancers metastatic to the adrenals, lung cancer metastatic to the brain. With no other disease anywhere, you will do a metastasectomy. Okay, along with the tumor in the lung, you will do this. What about if you have multiple lung tumors in there, multiple tumors in the lung, not lung tumors, but multiple tumors in the lung, but you do not know where it has come from? So first you will do a CT guided biopsy or a bronchoscopic biopsy. If you can't, then you do a wedge resection, identify it. In this day and age, it's very hard not to identify where it has come from. And if it has come from, let's say, a sarcoma sitting somewhere, you resect the sarcoma, give them the chemotherapy, repeat the PET or a CT. And if you have 3, 4, I have taken out 50 nodules and from the lungs, depending upon their lungs. So you can do a metastasectomy later on, but not at that time. First, you have to identify what the tumor is. Is that what your question was? So the previously we only used to, before the PET era, we only used to do the metastasectomy for colorectal cancers and sarcomas. Now we even do it for the breast cancers. Okay, and we have recently done quite a few for the breast cancers. We have done it for all cancers now. But if you have to, you have to have a diagnosis of the primary tumor, and you have to have a PET that it is not spread all over the body. Okay.
I just want to add here, you've got very specific criteria. So basically, as very rightly said, you have to identify the primary, and then you've got 5 criteria. So you have to have some systemic treatment option available for them. Their performance status has to be 0 to 2. They have to be living prognostically up to more than 6 months. And then what we have also done is actually working very closely with the surgeon. So if you have identified 3 metastases, for example, and you say, well, our surgical colleague will say, well, actually, why don't I take this out? And you do saber to that. So, we are increasingly doing that. And then our radiologist will say, well, actually, I can do RFA to that. So that's the trial that I was talking about again, Raymond, where we are actually comparing surgery versus RFA versus radiofrequency ablation. And it's for all comers. So even if you've got a large adrenal metastases, give it saber. If you can't operate it, give it saber.
Okay, Fawad.
Thank you. Thanks for a very excellent presentation. So my question is to any of you basically, and it's just stirring up a bit of a controversy. When you do a PET scan and you find 2 kind of nodules or lesions in 2 different on lobes of the lungs on either side. So one on, let's say, on 1 centimeter nodule on the right side, and then another 1 centimeter on the left side. How do you distinguish whether it's stage 1 cancers on both sides or it's M1A, or whether you look at the fitness? And for fit patients, you would say stage 1, and for elderly and infirm, you would say stage M1. Or whether it's, I'm talking to oncologist or surgeon, does that matter? So yeah, thank you.
Let Sundar answer this also, and others. So I've had 2 patients in over 32 years since I've been a resident, practicing, whatever. So I've had 2 patients in Pakistan, and it's tricky. They both are central, 1 centimeter. The bronchoscopy can't reach theirs. The CT guided biopsy can't biopsy it. And what do you do about them? So if the PET shows, and this is my own opinion, and I don't have a way to prove it, okay, because these are very rare cases. So if I have a tumor, which is two separate, first time patient has come in and they have a slight cough or nothing, and that's how they got the CTs. No other symptom, no loss of weight, nothing. I would treat both of them as first time primary lung cancers, okay? And if I can't biopsy them preoperatively, I would do a wedge resection intraoperatively and send them for frozen, and I will remove them, and I will do it bilateral lung resection. I've done this. How is it that it could not be from one lung to another other lung? It's a possibility, but then you have to explain it to the family. There's no way to prove. So I would remove both lungs. But the stereotactic, maybe just kill both of them with the stereotactic and then watch them later on. But I have removed both sides simultaneously because there was no way to prove.
Thank you.
That would be a wedge resection both sides, or
No, if they are in a segment which is in the center,
yeah.
I would remove both lobes.
Okay.
So right lower lobectomy on one side and maybe the left lower lobectomy on the other side.
Okay.
Both lobes, provided their functional status was great enough.
And what were the outcomes of those patients?
So
Because I think sometimes case reports can be very important in relevant.
absolutely. So one of them is around, okay? He's about 8 years out. He did get the chemotherapy because we could not decide the biology of both tumors. We could not figure it out. They both were adenocarcinomas, but we could not figure out whether they were of the same cell line or another cell line. I believed it was from a different cell line, but nobody believed me, and they went ahead with the chemotherapy, the whole 6 cycles. He's still around. The other person is lost to follow-up. I don't know what happened to him, but I have no actual answer to what he has said. There is no way to prove what it is, and it's not even written properly.
So very important question, and I think we are faced in the MDT about this literally all the time, just because the CT scans are so sensitive. And the principle that you always follow is give the patient benefit of doubt. So if you've got synchronous tumors, you would assume that both of them are actually primary, because you can then access everything. So very rightly so, if you have got tumors in operable areas, the surgeons will go and say, well, actually, I'm going to do a lobectomy here, but I might actually just do a wedge resection on the opposite side. It all depends on, what your patient's lung function and performance status is. If the performance status is 2 or around, again, you can actually do a lobectomy on one end and do SABR on the other nodules. Now, the other most important consideration, if they are metachronous, so they are coming 6 months later, only then in oligometastatic disease, you can actually do SABR. Otherwise, you can't do SABR. And the other most important consideration, and I actually had a very interesting case that I wanted to share with you guys, is I've got a lady who is 7 years post small cell lung cancer with bone mets only, and she developed a nodule. Now, her behavior is very weird, and we've questioned it time and time again, and I've actually had her histology reviewed as well. And we spoke to our surgeons, she got operated, and we got the histology back as non-small cell adenocarcinoma. So always think laterally. If your patient is not behaving in the average pattern, always get it biopsied.
Okay, I think we have just time for one last question. And so that our pulmonologist colleague is not left out, I'm going to ask him. He's talked about early warning alert system for small cell lung cancer, which is a very pragmatic approach. How does that work? If you can tell us.
Thank you very much, Fatullah. A very interesting question. Actually, that with small cell lung cancer, you have to be very, very quick to treat it. In NHS system, obviously, we have seen the patient. For example, we have done CT guided biopsy or EBUS, and we give them appointment, let's say, come back in 2-3 weeks. So, to diagnose small cell lung cancer, you don't need very sophisticated molecular testing, immunohistochemistry, etc. Just with one slide, pathologist can say, yes, this is small cell lung cancer, and that's it. Let's say patient had EBUS today, and tomorrow pathologists tell me that this is small cell lung cancer, I will not wait to see this patient for 2 weeks as planned before. I will immediately call the patient, bring them into my clinic on the same day or even next day, and alert my oncology colleagues and start the treatment as soon as possible. So that is how we have reduced the time from diagnosis to treatment. And interestingly, that improved the survival rate. So we have not spent anything really, and this is very, very cost effective. What I'm through this we are trying to say is that by adopting such system, in fact, after we adopted this, many other hospitals in NHS are doing this. Small cell lung cancer, especially at advanced stage, have to be looked after very well. And you know, one of the study from UK that overall, not just small cell, 24% of the lung cancer patients they had deterioration in their performance status while they are waiting to have treatment, and they were not eligible for treatment anymore. So we have to be very vigilant in these cases. Thank you. I hope I have answered your question.
Thank you very much. Thank you, Dr. Solat. Thank you, Dr. Sundas and Dr. Tafai. Thank you.